Hi, everybody. This is Julie. It's 1 o'clock. We looks like we still have people coming online, so we'll give it another couple minutes to make sure everybody's here, and then we'll get started. All right. Good afternoon, everybody. This is Julie Foster-Hagan. I'm the Assistant Secretary for the Office for Citizens with Developmental Disabilities. And I want to thank everyone for joining us today as we talk about complex care and our streamlining project that we've been engaged in related to complex care. I do want to let folks know that, as we go along in the presentation, you can raise your hand or enter questions in the Q&A and the chat, and we'll be able to recognize those as we go along. And I do want to just, before I turn it over, as folks can hear my dog barking in the background, just want to give a special thanks. We did work with some of you guys that are on the phone to be able to do this streamlining project. So thanks to those of you who participated with us as we looked at that. And we do truly hope that where we landed is something that works for everybody to make this process more efficient, to be able to get support for people with complex needs in place. So with that, I'll turn it over to Andrew, who I think wanted to say some introductory comments as well.
I want to just thank everybody for that helped along this project. It was a very, very involved project. We had lots of information from many different sources, many different stakeholders, and we do appreciate the feedback we've gotten. I also want to thank Marcus Bachhuber, the Medicaid Chief Medical Officer, that really helped with this project. It gave us the benefit of what I don't have, and Julie has a little more than me, but probably to a lesser degree than Marcus, that clinical side of things and how other reimbursement activities take place within Medicaid. So I want to thank him for that. I think this was a very good project, and we ended up with something that we all could be proud of, and it's going to make things a lot more efficient, both for the providers and also for LDH. And a little under the weather, so please forgive me if I'm seeming a little bit out of it. It's probably the sinus medicine. But once again, just want to thank everybody for their time, and also taking your time out of your day to take part in this training. So with that said, I'll turn it over to Mark.
Hey, good afternoon, everyone. As Andrew mentioned, I'm Marcus Bachhuber. I'm the Medicaid Chief Medical Officer. I don't think I've had a chance to meet many of you. Some of you, directly helped with this effort. And again, just wanted to thank you all, like Julie mentioned, and wanted to thank Julie and Andrew for bringing me in on this project and helping me understand the issues and work through it with you all. So why don't we just jump in? As Julie mentioned, we encourage participation. So if you want to leave a comment in the Q&A, raise your hand. just let us know. We're happy to answer any questions as we go along. It's meant to be interactive. All right. So just a refresher, I think we're all on the same page, but it never hurts. So complex care program is for clients with complex medical support needs. These are clients that require enhanced direct support, skilled nursing resources, or certain equipment. It's intended for clients that require more than the traditional direct support ratio, but don't require one-to-one staffing. Just like any program in Medicaid, the complex care program, there must be medical documentation for the need for the level of care. And to address provider concerns, we're really aiming to redesign this process in phases. This first phase we're going to talk to you about today is redesigning the request form. And then phase 2, we're going to be redesigning and developing the appeals process. And I just want to note for everyone before we move on that the new request form that I'll be describing to you today is effective November 1st, 2021. And we'll highlight that a few more times in the presentation just because that date is right around the corner. So first, I'd like to talk about some provider concerns that we heard that kind of led to this effort. The first is that there were burdensome documentation requirements and inconsistent guidance, some changing standards and rules, and providers have not always been informed of changes in a timely manner. And these are some summarized provider concerns, may not speak to all the concerns that you had or catch every detail, but in the general gist of what we heard from you all. So in response to that concern, we've really taken on redesigning the complex care request form to greatly limit the amount of documentation required, only ask for information used to actually make a decision, and to provide clear guidance on what documentation is required and what information it should contain. We think that with those 3 actions, it'll remove or address the vast majority of the concern. Another concern is a lack of transparency around LDH, the review committee's deliberation process, and the lack of an appeals process. So I think the main opportunity here is to, in the form redesign, to make the criteria more standardized. So there are clear and objective criteria for the add-ons on the form. This will allow the decisions to be transparent and predictable. Our goal is for providers to be able to determine for themselves whether their client is likely to qualify just based on filling out the form. Of course, we will be reviewing the form and making that decision, but we don't like to get into a guessing game with anyone for any program. Another concern is that there are delays in the complex care review and decisions by the LDH committee. So we think that, again, this concern will be largely addressed by streamlining the form and having objective, concrete criteria, because it'll improve the speed of review and decisions and reduce the time to prepare the forms. But as with any new form or any process change, there may be hiccups in the beginning, so we just ask that you all be patient with us. We'll also be working on transitioning the review process to Gainwell. That's the state's contractor that does prior authorization requests for fee-for-service Medicaid. And this would bring the complex care program in more alignment with how other programs are run. There's a clinical review, an appeal process, things like that. But we'll be working on that in the next phase of this project. So in summary, the main goals were to streamline the process for providers to ensure a more efficient use of resources, to streamline the review process by LDH, to update and clarify criteria to be clear, objective, and concise for the purpose of reducing confusion, to create a framework to render transparent and predictable decisions, and to create a fair and transparent appeals process. As I mentioned, that'll be the next phase. So this next part of the presentation will be going over a review of the screening tool. And this is where I hope that you all will ask any questions or any clarifications that will be helpful to your facilities. So this new form is effective on November 1, 2021, so that's next week. And it will take the place of the old form in its entirety. So starting November 1st, you'll be using the new form. The purpose of this form, or what we think this form accomplishes, is creating a single document that captures all the needed components for the folks receiving these services across the state, standardizes the way questions are asked and documented for better tracking, and it provides very clear expectations for both LDH and the provider. So the next few slides, I'm just going to go through the parts of the screening tool. And the first part here is pretty simple, and that's the client, section 1, the client information. So this is just the name of the recipient, facility, the current level of care, some insurance ID numbers, the person completing the form, and contact number. This section of the form hasn't really changed that much. The next section of the form is the direct support worker add-on request. So the direct support worker add-on is only available when staffing is being provided above the minimum staffing requirements. And there you can see it's the general guidelines. So to justify the direct support worker add-on request, a facility has to certify or verify the client's need with assistance with the various activities. So the chart has a list of activities. These are activities of daily living, although people classify the activities differently. But this list is the activities of daily living, and then facility will mark off whether full assistance is needed, partial assistance is needed, or no/minimal assistance is needed. The activities listed are transferring, so moving from a chair to a bed, mobility, getting from one room to another, so propelling the wheelchair or walking, turning and repositioning while in bed or in a wheelchair, eating, bathing and showering, grooming, physically dressing, and continence and toileting. So to qualify for the direct support worker add-on, the client must require full assistance with 4 or more activities. That's just one of the criteria. There's another one we'll get to in a second. Just in recognition that not everyone who needs a direct support worker add-on will have or require assistance with 4 activities, we allow providers to document complicating factors or risk factors that would justify the direct support worker add-on. So for example, if someone could only, someone only needed assistance with 2 or 3 activities, but they had one of these complicating factors, they may still qualify for the direct support worker add-on. And the complicating factors that we identified were a documented history of falls, skin breakdown, sensitivity to touch or combative or agitated behavior, dementia with confusion or disorientation, more than one person required to safely lift, transfer, reposition, bathe, or dress, contractures, and then dysphagia, which requires supervision while eating. You can see next to the box for each complicating factor, there's a box that is the description. So the facility or the provider will enter a description of the issue. So at the end of this section, there's just a note that documentation should be provided to verify the above needs. And there's a documentation checklist at the very end, which we will get to. The last piece of the direct support worker add-on is the duration of the request. So the provider or facility can indicate the duration of the request, and then LDH, we will review it and determine whether we agree or think it should be for a shorter period of time based on the documentation, and requests are limited to a maximum of 1 year at a time. So I'm going to pause there for a few minutes and see if there's any questions or comments or any clarifications from the group.
I don't see anything in the Q&A or chat, Marcus, and I don't see anyone with their hand raised. So just as a reminder, if you have questions, oh, wait, one just popped up when I said that. Can we print these documents?
Yeah, so we'll be sending out the form to the providers, Julie, correct?
Yeah, that's correct. Yeah. We the same way that notification came for this meeting, and we normally use the health standards, kind of the blast method how they blast information for us. So it will be sending it out. After we have this webinar and a webinar on Thursday. So we'll be sending that out. Andrew, can we go ahead and send it today and blast it that way?
I mean, that's an option. I think we should training, but that's just in my opinion. I'll defer to whatever you, Marcus, think is best.
Yeah, I think we were trying to make sure we had an opportunity to talk through it before we sent it out, which was why we were going to send it, but we can send it immediately after the second webinar on Thursday, for sure. So then again, just as a reminder, if you want to be able to raise your hand, if you know how to do that, or if not, you can enter a question in the Q&A or the chat, and we can take you off mute to be able to ask the question. But I don't see anything else at this time, Marcus.
Okay. So I'll go on to the next section, but if a question comes to anyone, feel free to go back to the direct support worker. We can definitely go back. All right. So the next section is the skilled nursing add-on request. So skilled nursing refers to care that can only be provided by a clinically trained and licensed nurse. So there are often things that we may think of as a nurse would be good at, or it would be helpful to have a nurse do. But the purpose of this add-on is really to focus only on things that can only be done by a skilled nurse. So the baseline requirement here is that a skilled nurse be on the home for at least 16 hours per day. And that's a long-standing requirement of the program, so there's no change there. So to qualify for this add-on, a client must need 3 or more of the below skilled nursing needs. And to get this list of skilled nursing needs, we looked at other programs in Medicaid, we looked at the Medicare program, and we worked with some of the providers on the line here to help develop a comprehensive list of skilled nursing needs that their clients may have. So to qualify for a skilled nursing add-on, a client must have 3 of the below. And the skilled nursing needs are nasopharyngeal, tracheal, tracheostomy, or oral suctioning, enteral feeding with complications such as reflux, agitated behavior, or contractures, urinary or vesicostomy catheterization or care, colostomy care, nebulization treatments and nebulizer care, ventilator or positive airway pressure device care, diabetes care with injectable medications. So that would be insulin and other injectable diabetes medications. Oral pills alone wouldn't be sufficient for that. Administration of intravenous, intramuscular, subcutaneous injections other than diabetes medications, because that's counted above. Wound care involving prescription medications and dressings with aseptic technique. So minor wound care, like first aid, for example, for a cut or a bruise that's small, that wouldn't qualify. We're talking more about pressure ulcers or surgical wounds, things like that. Administration of 5 or more different medications per day. And it can be a combination of oral and topical medications. And then 3 or more skilled nursing assessments per day. So again, these are assessments that can only be done by a skilled nurse. We think of those, some examples might be neurological checks or glucose measurements. So as before, documentation needs to be provided to verify the above needs. We know in healthcare settings, generally, there's a lot of patients that have a wide variety of as-needed orders that can ensure the patients have appropriate treatment when they need it. But for this case, the presence of an as-needed order really is not enough to demonstrate need. The documentation must show that the service is being provided routinely and delivered by a skilled nurse. The last piece of this is, again, I cut it off because it's the same as the direct support worker, but the facility should specify the duration of the request. So again, limited to up to 1 year, and then LDH will review the documentation and make a decision. I think I saw a message in the chat, so let's see if I can open that up. All right. If a patient meets more than 4 criteria in the checkoff, do you have to go to the next part of the DSW add-on? That's a great question. No, you don't. If the patient meets, I can go back to that screen here. So if the patient meets the 4 criteria outright in this table, you don't need to complete any of the complicating or risk factors. You can, just for the sake of completeness, but it's not necessary for us to make a decision if you meet the 4 activities here, the 4 or more activities outright. So I will pause for a moment for the skilled nursing add-on request and see if there's any other comments. I don't see anyone with a raised hand or any chats in the Q&A, but.
Yeah, I don't see any either, Marcus.
All right, just give it a second here before we move on. Okay. So the last piece is the equipment add-on request. And this add-on is available when clients need certain types of supplies. This add-on is only applicable to clients with Medicaid only and no other insurance. For example, clients with both Medicaid and Medicare are not eligible. And the 3 types of equipment for this add-on are enteral nutrition or tube feeding supplies, and that doesn't include the supplemental feeding. This is when the person relies primarily on enteral feeds. Ostomy supplies and tracheostomy supplies. This is the historical equipment add-on request, the historical scope of the equipment add-on request. There's no changes here. Similar to before, documentation must be provided to substantiate the needs. And the facility should indicate a duration of the request, which we will review. Any questions on this one? Okay, I'm not seeing any raised hands or any anything in the chat box. So we can move on. The next section is the attestations. And so for all of the add-on requests, there are 2 attestations that need to be completed by the facility. The first is a clinical attestation that must be completed by a licensed clinician operating within the scope of practice. So depending on what add-ons are being requested, the clinician that is allowed to complete this attestation is different, and the instructions are there in the intro. So if it's a direct support worker add-on, the equipment add-on, or both, it can be signed by a physician, advanced practice registered nurse, nurse practitioner, physician assistant, or an occupational physical or speech therapist. If the skilled nursing add-on is requested either by itself or in combination with any other add-on, the attestation must be signed by a physician, APRN, nurse practitioner, or a physician assistant. The second attestation must be completed by the executive director of the facility. And this is an acknowledgement of an understanding of the rules and regulations of the add-on requests, and also the rules and regulations specified in the Louisiana Administrative Code, including the direct care floor. The executive director will also attest that staff will operate within the scope of practice of their license, and supervisors of unlicensed personnel will ensure that all people operating under their license are properly trained and demonstrate competency in the skills needed. And then an acknowledgement that they'll abide by all LDH rules and policies. Most of this stuff is pretty standard. I mean, all this stuff is pretty standard operating procedures for all the providers, so there shouldn't be any surprises to anyone here. I see there was a comment in the chat. Let me just see if I can open it up. The question is, does the patient have to meet more than on criteria to get equipment add-on? I'm not exactly sure what you mean, but just to review the equipment add-on again, the equipment add-on is available for clients who have any of these three equipment needs. All right, and then there's a question, is this an additional rate that can be charged by a facility in addition to the standard Medicaid rate? Andrew, Julie, I don't know if you want to take that one.
What was the question, Marcus?
The question was, is the add-ons an additional rate that can be charged by a facility in addition to the standard Medicaid rate?
It is an add-on to the per diem. That's what the question is. So,
yeah. Okay.
Yeah. So when the, sorry, this is Julie, just to provide a little more clarity on there. The when you know, if you're supporting people who have complex needs and you do have additional direct support workers, and then we'll get into the nursing momentarily, or nurses that are in the home 16 or more hours a day, or the equipment needs, you know, and you are providing that, then yes, you can request the add-on through the complex care, or any of those three can each be looked at individually or in combination with each other. I think maybe part of the question as well.
Okay. So we'll move on. The last section is the documentation checklist. And the purpose of this documentation checklist is to help providers gather all of the information that we need to make the decision. So the form puts it all in one place, and then we need to see medical documentation to support the needs stated. So we require every add-on, all add-ons, you know, alone or in combination, need to go through this checklist and check off the appropriate documents. So every add-on request needs a letter of medical necessity, and it must describe the client's needs in the request form and be signed by a licensed clinician. The same rules here apply as the attestation. If only the direct support worker or the equipment add-on or both of those are requested, the letter of medical necessity may be signed by a physician, advanced practice registered nurse, physician assistant, or occupational, physical, or speech therapist. If the skilled nursing add-on is requested alone or in combination with any other add-on, the letter of medical necessity must be signed by a physician, advanced practice registered nurse, or physician assistant. So for the direct support worker add-on, the three documents that we require are the staffing schedule for the previous 2-week period that shows staffing above the minimum. The minimum is generally 1 to 4 during the day and 1 to 8 at night, but it may vary based on the clients that you have or the level of care of the clients. The next document is the functional assessment by a licensed physical or occupational therapist within the past 90 days with specific instructions for the direct support workers. We know that many of the clients have lifelong disabilities and lifelong needs that may or may not change over time, but we do need to see updated therapy assessments in order to understand the nature of the direct support worker services needed. And that's a general requirement for all of our other programs, including home health, pediatric day health care, other programs. We need to see periodically updated assessments. And the third is for those with swallowing disorders, so it doesn't apply to everyone, but for those with swallowing disorders, an assessment by a licensed speech language pathologist within the last 90 days. And that's for direct support worker activities around mealtime or communication instructions. The equipment add-on the only documentation needed is just documentation of the client's equipment needs. And that may be included in the letter of medical necessity, the functional assessment, or the nursing documentation if it's applicable. So it doesn't necessarily need to be a separate document. It's probably included in the other documentation because often that equipment is needed by the skilled nurse to do the service that the client needs. The last items on the checklist are the skilled nursing add-on. These are two documents that we need. One is the nursing staffing schedule for the previous 2-week period. That allows us to determine whether the nurse was on the home for 16 hours or more per day. And also the nursing documentation for the prior 2 weeks, demonstrating the skilled nursing needs and activities that were performed by a nurse. So that's the end of the form review. And so I'll pause here and see if there's any questions or comments or anything anyone wants to add in.
I don't see any hands raised.
Someone just asked, someone just now popped up.
Oh yeah, there's a question. Is there any way you can add an email to the blast in order to receive these forms? I believe we can do that. I would imagine we can do that. All right, so this was, oh, we have another request to be added to the list. I think we can do that. This is the last slide I have for any questions and contacts if you want to reach out to us. Remember that the new form is effective on November 1st, 2021. So we'll be sending that out. And I just want to give one last opportunity for any other questions or comments. I hope I didn't move too quickly for anyone. So we have one question. If someone receives more than 1 to 8 at night, but still 1 to 4 during the day, would they qualify? Let's go back to the. I think we can take that one back and bring that back to the group. So we have, what is the timeline for the appeals process rollout? We're looking over the next 2 to 3 months, depending on how the form goes. We don't want to introduce too many changes to the system at once. We think the form should really reduce a lot of the need for appeals by creating a more clear and transparent request. Can we get a copy of the PowerPoint? Yeah, I don't see why not. Can a patient receive complex care and pervasive plus? Julie, I don't know if you want to take that one.
I'm actually going to punt it to Andrew if he can answer. I know we had kind of gone back and forth on that.
Yeah, to the best of my, we would have to get verification from the complex care team as it is now, but I believe you can receive both. Now, let me verify. Let's get some verification from the complex care team. My thought is yes.
I'm sorry, Andrew, we're having a little hard time hearing you.
That's because I'm having trouble speaking.
Sorry.
I'll take that back to the complex care team, but if memory serves, the answer, I just got confirmation, yes, they can.
Okay. Okay. What is the timeline for transition of the reviews to Gainwell? So beginning November 1st, the new form will be in use, but providers will continue with the old process of emailing the form and the documents. We will then have those reviewed by Gainwell who will start with the reviews on November 1st, and then work on the back end with us to get approvals and payments and all that stuff. Over the next few months, we're going to be working with Gainwell to have it be more of a self-contained process where they have an electronic PA system that providers can just directly submit forms and documentation to. And then Gainwell will make the decisions, communicate to the department, and then the payments can be authorized. So the transition of the reviews to Gainwell will happen in 2 phases, one on November 1st, and then one probably late spring, mid-spring next year. Just want to make sure we get the electronic prior authorization interface working correctly. Any other questions or information that we can provide? Can we get a copy of the current add-on rates? Yeah, I believe we can send that out. Question is, in the past, I've been limited to submitting 2 packets per week. Will this continue with the new form? No, that will not continue. You can submit the forms as you need them, as you feel that, or as the facility believes that is appropriate.
Marcus, just to clarify for the pervasive plus complex care question, those are still 2 separate processes and not combined just yet. So that would, pervasive plus process, that still would remain as it currently is. We have not modified that process even after November 1st.
Okay. Last call for any questions or hand raising. Oh, question, can I repeat the answer to your question? Your computer cut out. I believe your question was, in the past I've been limited to submitting 2 packets per week. Will this continue with the new form? The answer is no, that will not continue. The providers can submit forms as they deem necessary. You're welcome. All right, I think,
Okay.
Yeah.
Yeah, no, I was just going to say, I don't see anything else. I think our takeaways, there's been an ask that we share the forms, the PowerPoint, and a copy of the add-on rate. So we've got that documented, and those are our takeaways. We'll look at submitting all that after. We wanted to make sure we had opportunities for 2 webinars for folks who may not be able to attend this one. So, and for those of you who, got the information about both, the webinar on Thursday will be this exact same information. So there will be no new information presented on Thursday. Once we have an opportunity to explain that, we'll then be getting, that information out, and we'll work to see if we can add those, the names or the email addresses for the folks who requested that we do that. So. All right. Well, thanks everyone so much for your participation. We know that you may have some more questions. If you're like me, you'll hang up and go, dang it, I should have put this question in there. So, you have our email addresses if you need to email one of us with a question, and we'll make sure that we get a response out to folks and make sure that our information is clear. So, again, our overall goal was to try to be a little more direct and transparent and about the reviews and how they were happening. And we hope that this does make things work more efficiently, both internally and externally for folks. So we appreciate your time and attention to this matter. Thanks so much, everyone.